This week on the BackTable podcast.
I think you have to choose one technique, because, I have seen surgeons, they try to change all the time and they start with one kind of surgical technique and then 2 months later, they try to do something different. And then if you do that, you never get very experienced in one single, way to do a radical prostatectomy. So what I would recommend, choose your technique. There are many ways to do it. And once you choose it, you should get very experienced and optimize your outcomes by surpassing the learning curve. And so this, I think, is the key point for having good outcomes long term.
Hello, everyone, and welcome back to the BackTable podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, and at backtable.com. This is Aditya Bagrodia as your host this week, and I'm very excited to introduce our guest today, Rafael Coelho from the University of Sao Paulo in Sao Paulo, Brazil. Welcome to the show, Rafael. How are you doing today?
Thank you for having me here tonight.
Oh, it's absolutely my pleasure. So I had the good fortune of going to USB and working with Rafael, and I've always thought I could do a pretty good prostatectomy. I've seen a lot of people that do what I thought was a really good prostatectomy, and I got to say, the prostatectomy Rafael does is absolutely outstanding. And when I was thinking about a surgical tips and tricks, it was top of the list that came to mind. So, excited to pick your brain. And maybe let's just start out with, what is the fundamental information that you're getting from the patient, imaging, pathology, functional status, when you're considering a patient for a prostatectomy?
So, I think I have to combine everything. It's really a procedure that we should tailor for each patient. So we look at the MRI. Every single patient gets an MRI prior to surgery. So we use that for nerve sparing. Basically, we know that MRI has a very high predictive value for extraprostatic extension. So when the MRI is positive, we believe that it's positive, and we go for partial nerve sparing or maybe no nerve sparing procedure for advanced disease. But for those patients that have a negative MRI, but like a high volume intermediate risk disease, we use nomograms. So we published one of these nomograms a couple of years ago, using the data from 12,000 prostatic lobes. So it's a nomogram based on clinical parameters. And that's these are the patients that I think nomograms can help. When the MRI is not conclusive, it's a negative MRI in terms of extension. But then you have a lot of Gleason 4+3 in the biopsy patients that I think they might have a microscopic extraprostatic extension. So we do combine the data from the MRI and nomograms in order to plan your nerve-sparing procedure prior to the radical prostatectomy.
Excellent, excellent. And we'll kind of talk into some of the nuances when you're actually doing it, no nerve sparing, partial nerve sparing, etc. What about bladder neck sparing? Do you use that routinely, or is that also going to be based on the imaging?
Oh, that's interesting. I think it's a lot of controversial data on the impacts of a bladder neck sparing in terms of continence. I think if it does have any impact, it's in early continence, maybe not long term. Long term, I think it doesn't make change if you have bladder neck sparing or not. But we usually try to do a small bladder neck, not a very aggressive dissection like the French school, or those guys, they do like a urethral dissection. They do a circumferential dissection of the bladder neck. Because at the end, all you get is like preservation of the mucosa, which doesn't make any difference in terms of continence, in my opinion. So if I don't have a patient with a lot of disease in the base of the prostate or the bladder neck and the imaging or biopsies, I would go for what I call a partial bladder neck sparing, just make it small, when I don't have to do a lot of reconstruction afterwards. But again, I don't think it does affect continence long term, and most of the data shows that maybe there's impact in early continence, but not long-term continence. I don't think it makes any difference long-term.
Yeah, when I talk to the residents and fellows about the bladder neck, I say there's one of three possibilities here. A, you get a perfect, nice, compact bladder neck. B, you have a larger bladder neck that you can reconstruct. Or C, you get into the prostate. And the only option that's unacceptable is option C. So yes, I think a nice small bladder neck that's compact and and even potentially continent during the operation is nice. But as you mentioned, if it's slightly larger, or even if you have to reconstruct it, you can certainly salvage that long-term continence outcome. And then what about, the apical dissection? If the tumor is at the apex or into the stroma, do you approach your apical dissection any differently?
So this is interesting. The way I'm doing the prostatectomy today, I don't ligate the DVC at the beginning of the procedure. I go just underneath the dorsal venous complex, which I think this makes sense. This does make difference in my personal experience in early continence. So instead of ligating the DVC, we develop this avascular plane between the dorsal venous complex and the prostatic capsule anteriorly. So that's what I usually do. And when it's an anterior tumor, sometimes with an extraprostatic extension anteriorly, then you have to change your kind of dissection. I still do not ligate the DVC at the beginning of the procedure, but in those patients, I leave parts of the dorsal venous complex into the prostate, covering that tumor. So you're going to have to cut through the DVC at some point, and it's going to bleed a little bit more. This is when I just increase the neuroperitoneum pressure. But then I like to go a little bit wider anteriorly. But even in those situations, I think it's better if you don't ligate the DVC, because when you ligate it at the beginning, there's only one spot where you can cut the DVC if it's ligated from the beginning. So you cannot tailor the procedure according to the risk of an extraprostatic extension. So I do approach it differently, but again, I don't ligate the DVC at the beginning. In any case, I always left to the end of the procedure. And again, if there's a large tumor in the apex anteriorly, I cut through the DVC. I leave part of the dorsal veins into the prostate in order to avoid a positive margin.
Yeah, I think, once we start talking about these things systematically, I certainly always cut the DVC before I ligate it. And I think I think about it like your DVC is draped over the urethra to some extent. So either you're going to incompletely ligate it, or you're going to maybe potentially get a little bit of the anterior-most aspect of the urethra, or you're going to be so pigeonholed into where you're going to cut based on your DVC stitch that you may not cut in the exact proper spot. So that's a modification. So maybe like just backing up a step, so you're seeing a patient and you kind of mentioned if they've got some higher risk features, you use nomograms to dictate nerve sparing or not. And, of course, that's in the context of your MRI. Bladder neck sparing, it sounds like, if it's a good option on base of the tumor right there at the, transition zone, it could be a good option. But what about a lymph node dissection? How do you decide who's going to get a node dissection? Does everybody get a node dissection in your hands, and what the extent is going to be?
So this is interesting because we changed this recently. We published about 2 years ago a randomized trial on lymph node dissection in patients with intermediate and high-risk prostate cancer. It was the first randomized trial published ever evaluating the oncologic outcome for patients undergoing radical prostatectomy. So what we found in the study, we randomized 300 patients to an extended versus limited lymph node dissection with intermediate and high-risk prostate cancer. The main outcome was biochemical free survival. And what we found, it was a negative trial when you look at the overall cohort of patients. So there was no benefit of an extended lymph node dissection for these patients when you compare to a limited lymph node dissection. But when you look at the subgroup analysis that we did, those patients with a Gleason score 8, 9, and 10, those patients had a benefit. They had a potential benefit in terms of biochemical recurrence. And we tried to look at all nomograms out there, look at the Briganti nomogram, the Memorial nomogram, and we tried to find what is the best nomogram to predict those patients that benefit of an extended lymph node dissection. And that's what we found in our study. Gleason score is the major predictor for those patients that will benefit in terms of biochemical recurrence. So we changed it. You used to use those nomograms in order to select patients to do an extended lymph node dissection. You look at the EAU guidelines. If you have a predicted risk of positive node higher than 6%, sometimes, they just choose a cutoff. That was we were using in the past. After we published our trial, I just used Gleason score. This is in our series with the only way to select patients that may have a potential oncologic benefit with an extended dissection. So that's what we do. All patients with a Gleason score 8, 9, and 10, we do extended. Patients with intermediate risk, but not with intermediate risk, not Gleason 8, 9, and 10, we do a limited lymph node dissection. Those patients are included in the trial. And the low-risk patients don't get a lymph node dissection at all.
Yeah, I think that's probably pretty reasonable. I feel like I've generally moved away from offering surgery as much as possible. I mean, sometimes it's patient preference for low risk, Gleason score 3 + 3 = 6, grade group 1. And I struggle with it, for 3 + 4 = 7, relatively modest PSA that I'm not overly worried about. I feel bad omitting a lymph node dissection at all whatsoever. And then I oftentimes will just do a bit of a extended, common iliacs and beyond, recognizing that the value added of doing that is extremely small, and that, the risks are generally fairly well tolerated, but, by all means, I've had a lymphocele or an infected lymphocele, et cetera, and, it can be a problem. But wholeheartedly agree that the grade group is going to be what kind of takes the day here, unless it's a very high PSA. And I do think that this is also going to evolve, as next generation PET imaging becomes more and more of an armamentarium for working up high-risk patients. And, maybe not the point of this discussion today, but how we're going to deal with folks with, some suspicious lymph nodes in the pelvis. So, when I think about a patient and that you've made the decision to go to surgery, the things that I can control as a surgeon are going to be the extent of my lymph node dissection, whether I take a wide or a smaller bladder neck, whether I take an extended pedicle or nerve sparing, and whether I stay close to the prostate or whether I go a little bit more distally for apical tumors. And those are the kind of factors that I'm broadly thinking about. If it's an anterior tumor, sometimes I'll send the periprostatic fat as a anterior prostate margin. Are there any things beyond that, kind of from an oncologic perspective, that you consider, Rafael?
Well, I think these are the main variables that you should have in your mind when you're doing a radical prostatectomy. I think the one that makes the difference at most for me is really the way we do the nerve sparing procedure, because this is going to affect your oncologic outcomes in terms of positive margins and also the functional outcomes. So, again, bladder neck sparing can have an impact on early continence, but really what makes difference in my experience is the way you do the nerve sparing procedure. So that's my main concern when I'm planning a radical prostatectomy, is really how am I going to do it? Am I going to do a retrograde release of the neurovascular band? Am I going to do a partial or full nerve sparing? How can I avoid a positive margin and still have a good functional outcomes? And this is really all about nerve sparing, in my opinion. But nerve sparing is not like we taught in the past. It's not only the posterolateral dissection of the prostate. It does include the anterolateral dissection as well. As we said, we're not like getting the DVC at the beginning of the procedure anymore. And so we gotta preserve these anterolateral neurovascular fibers, which are actually part of the nerve sparing procedure. So it's not that we do nerve sparing, DVC, ligation, apical dissection. It's all part of the same surgical procedure. Either you go very close to the prostate or you go for a wide dissection, and it's all connected, right? So it's all part of nerve sparing, in my opinion, and that's how I try to plan my procedure, how I'm going to do the nerve sparing on the left, on the right, and this is really the key for having a good outcome of a radical prostatectomy, in my opinion.
Yeah, I appreciate that. And it is absolutely all related. And, it's definitely kind of patient specific also. So how about broad strokes? So approach, I do a posterior approach. And, the first thing I do is actually the lymph node dissection. I like to just do that while I'm fresh. I think it is human nature sometimes, if you've had a long case, tough case, that you say, okay, maybe they're not that high risk. Let's do a bit less lymph node dissection. So the first thing I do is little nodes. And as I mentioned, I kind of find the ureter, medialize it, and then do my common iliac, external iliac, hypogastric, and optical lymph nodes. Then I go immediately to the posterior dissection. And I have not embarked on Retzius sparing approaches, because I think I do some technical modifications similar to yourself that recapitulate some of that. But broad strokes, any kind of opinions on functional or oncologic outcomes using anterior versus posterior approach?
Well, I have done some of the rectus sparing procedures, and in my opinion, it doesn't improve any continence or sexual function if you do an anterior approach with preservation of the dorsal venous complex and the anterior arcus tendinous. The final aspect is actually the same, because what I did in the beginning, I did some rectus sparing procedures, and at the end I took down the bladder just to look how the way it was, it looks exactly the same. So, and when you do rectus sparing, you have a lot of difficulties in terms of bladder neck dissection. You are not that used to the kind of anatomy, and you tend to go very close to the prostate. So I don't think it's safe to do rectus sparing for a locally advanced disease. And actually the data shows that the margin rates are actually very high for rectus sparing procedure. The positive margin rates are higher if you do rectus sparing locally advanced disease. And you don't see any benefit in terms of functional outcomes if you are comparing to anterior approach with preservation of the endopelvic fascia and the dorsal venous complex. So why should you do posteriorly, which is much more difficult? We are not used to this kind of anatomy. So, you have to do the anastomosis, it's all inverted. Sometimes it's kind of mess, and why should you do it if you're not going to benefit patients? So I did like 10, 15 rectus sparing procedures, and I found that the outcomes are not getting any better than the outcomes that I had before. And I'm really running the risk of having a high risk of positive margin. So I don't like it, honestly, the posterior approach for, not for the seminal vesicle dissection, that I think it's okay, but doing the whole procedure rectus sparing, I don't like it. What are your thoughts on that? Have you tried it? You like it?
I have tried it, and I also don't like it. So, and I totally hear you 100%. So, one of the parts of the case that I'm very meticulous about is actually the incision of the endopelvic fascia. I incise the endopelvic fascia. Of course, there's people that don't. But, I start out towards the base, mid-prostate, make a small incision, slide in my scissors, and then come as medial as possible to the prostate and cut, making sure to leave the arcus tendinous and the puboprosthetics intact. And when I sweep off, I make sure I'm sweeping posteriorly so the fascia remains on the endopelvic on the levators. And then when I cut, this was after coming to Brazil, I also very much like the dorsal venous sparing approach. And, I think leaving that infrastructure in place that tethers the urethra anteriorly and provides support. So now you've got your arcus tendinous, you've got your levators, and then you've got your DVC. I totally agree. And I didn't see any kind of benefit in my early continence rates. And I liked it from an oncologic perspective better. So the first thing I do is dig out my VAS and my SVs. If I can get into a good nerve sparing plane from posterior, fine. But also if it's a posterior tumor and you've really got to get into, onto the perirectal fat and take things wide, I find that the rectus sparing becomes a little bit more challenging. You almost have to be in the intrafascial plane, in my opinion. So I didn't like it, but I do these modifications, staying close to the prostate, leaving the arcus intact and sparing the DVC, that I think actually kind of recapitulate many of the benefits of rectus sparing.
Yeah, that's what I usually say. Well, then when these guys say, look, my continence rates are better with rectus sparing compared to the anterior approach, I say, look, it depends what you are comparing rectus sparing to what kind of anterior approach, because there are many ways to do anterior radical prostatectomy. So if you're doing an anterior approach, but with all these details, all this preserving the arcus tendinous and all the anterolateral neurovascular structures, then it's different. Then it looks exactly the same at the end of the procedure. So it's not comparing rectus sparing versus anterior. It's comparing rectus sparing versus what we call ultra preservative technique done anteriorly.
Totally. And I mean, it kind of makes sense that, if you have your bladder suspended in the upper abdomen to the transversalis fascia, that's not really going to impact your continence. It's really what's kind of happening at the level of the, essentially the bladder neck prostate urethra junction. So if I may, for maximal continence preservation, it sounds like bladder neck sparing is preferred, not mandatory. Oncologically sound maintenance of the anterior structures, the DVC specifically, the arcus as much of the endopelvic fascia as preferred. And then do you try to dissect out the apex very much if it's not an apical tumor?
Well, I try to minimize the dissection of the apex as much as I can. Like that's, I thought, was one of the problems when you ligate the DVC. You usually over dissect the apex and the retrosphincter. And that's why I think the early continence rates are not as good as I have today. And, you know, I did my fellowship with Patel, and at that point, he was ligating the DVC, putting a suspension stitch at the beginning, and he was clearly overly dissecting the urethra, and the early continence rates are not as good as we are having today. So this is some of the key steps, in my opinion, when you're doing a prostatectomy. Don't touch that much, don't touch the urethral sphincter, just minimize the dissection, go close to the prostate, especially if it's not a apical tumor, and that is really the key for early continence rate. It's not really doing rectus sparing, in my opinion.
Yeah, I agree. I think sometimes when you're a trainee, it's so nice to just keep dissecting when you're in a good plane, and then you see your DVC and you see the urethra, and 100% have kind of shifted away. Once I'm able to kind of tell where the shoulder of the prostate is, the apical shoulder, then I'm kind of done. I do, if it's a bit more of a DVC ligation, I do suspend it to the pubic bone, actually at the end of my urethral anastomosis. Do you have any opinions on suspension stitches, Rocco stitches for enhancing continence?
Oh, I do exactly like who. I finish my anterior reconstruction and I do suspend to the pubic bone. When I was a fellow, we did a retrospective study with Patel, and it did show some benefits in terms of early continence. Because though I think that you bring the urethra to the initial position in the pelvic floor, the angulation of the urethra, it's kind of reconstructed by the suspension stitch. And also the Rocco stitch brings the novulus, brings the rhabdosphincter towards the pelvis to its initial anatomical position in the pelvic floor. Because when you cut it, the rhabdosphincter slides distally. So I think it does make sense to do the Rocco stitch. And also there's some other benefits in terms of taking the tension out of your anastomosis. There's some benefits in terms of hemostasis. There's some veins that bleeds right behind the urethra. So I like doing the Rocco stitch. We have, again, a retrospective study showing some benefits in terms of early continence. I'm not totally convinced that we are changing the continence rates by doing this anterior and posterior reconstruction, but I think it does make sense. It improves hemostasis, it takes the tension out of the anastomosis, and you reconstruct the anatomy to, it's similar to what it was before your surgery. So it does make sense to do it. And we don't have enough data, level 1 data, to show that we are improving continence, but I think that makes a lot of sense to do all these reconstructions at the end of your procedure.
Yeah, fair. Just try to get back to as much near normal anatomy, and starting with not disrupting it extensively. First things first, as much as you can leave intact. And how about deciding if you're going to do a bladder neck reconstruction? Are you doing that frequently, infrequently, and what is your preferred technique, Rafael?
So as I said, I try to make the bladder neck small. It's not an aggressive preservation. So most of the times I don't have to do a bladder neck reconstruction. It has to have a prior TURP or median lobe. In those cases, you end up having to do a reconstruction. So I usually do like a lateral plication of the bladder neck. I think it's the easiest way to do it, and this is the way that I learned with Patel. And usually I do like this, but when it is a very large prostate, very large median lobe, that I'm afraid that I'm gonna have problems reaching the urethra with the bladder neck, then I reconstruct it posteriorly, like we used to do in the open radical prostatectomy. So in some special cases, when I think that I may have problems reaching the urethra with the bladder neck, I try to reconstruct it posteriorly so I can have a better, I can bring the bladder down, all the way down to the urethra easily. But most of the times I just do this lateral plication, one each side of the bladder neck, and it's usually enough to have a small bladder neck which is going to match the size of the urethra. That's what I usually do.
Yeah. So one of the surgeons that actually had among the best functional outcomes at Memorial would routinely take a fairly large bladder neck. And then after he completed the posterior plate of his anastomosis, he would put a catheter all the way across. And then on the bladder, starting at the cranial most side, just take a V-lock suture and run it right down until he was literally at the exact same size of the catheter, 1618 French, and then complete the anastomosis. I've adopted that way because I feel like you never have to worry about like getting the UOs or anything like that. Those are well visualized. You're never guessing at the size of your final bladder neck. And, as you rate it down, if you want to tighten it up even a bit more, you can. But that's what I go with. And I would say I probably do a reconstruction maybe once every 20 to 30 prostatectomies, but I have no problems doing it. And I would love to know if, a 1 centimeter bladder neck is any different than a 1.5 centimeter bladder neck that's reconstructed down to a centimeter. But yeah, I think, the posterior technique, the lateral technique, the fish mouth technique, or this anterior tennis racket are all reasonable. And I always tell the residents, find one that resonates with you, that makes sense with you, commit it to your memory so that when you do have to reconstruct a bladder neck, you know exactly what you're doing and you have a plan. Anything beyond that, extensive reconstruction of the endopelvic fascia, re-sewing it back to the fascia of the levators, anything beyond that, or pretty much a suspension stitch and a Rocco stitch for you?
Well, that's what I usually do. I do suture the bladder neck to the arcus tendinous sometimes, mainly for hemostasis, because sometimes you'll cut some of the dorsal veins. Then in order to do the hemostasis, I suture the dorsal veins in the arcus tendinous to the anterior bladder neck. Not that I think that it's going to change in terms of continence, but just to do hemostasis and actually reconstruct the initial anatomy, because the bladder neck was actually attached to the arcus tendinous. So I usually do that because, again, I think it makes sense to do it. I'm not totally convinced that we're changing outcomes by adopting those technical modifications. Well, something that I change is when I'm doing salvage surgeries or post-radiotherapy, then I'd rather have a large bladder neck and remove all that bladder that got a lot of scar with the radiotherapy. And I'd rather to the very large bladder neck and reconstruct the bladder neck with healthy tissue, in my opinion. Then I like to have a large bladder neck for those salvage cases. I think makes sense. So, and I have a very low rate of bladder neck contracture after salvage cases by doing a very nice bladder neck reconstruction instead of trying to preserve it.
Yeah, that's an excellent point. I hadn't thought about that. It's a good thought. Okay, so we talked about, kind of the factors for consideration for oncologic control. I think we've covered some of the main components of a bladder neck dissection, the apical dissection, and the various reconstructive options. And then, of course, is, preservation of potency. And when I'm talking to patients on the front end about risks and benefits of prostatectomy, when it comes to continence, I'll say, here's the rates, et cetera. And then off the record, barring anything unusual, you should be dry. By 9 months, at the latest, you should be dry. Then I'll say, for potency, it's much harder to predict. That, everybody's tissue plans are a little bit different. And, I will usually be a little bit more conservative on the sexual function outcomes than I would about the urinary component. Do you have any comment on that?
Well, I agree that long-term continence is usually not an issue with a radical prostatectomy nowadays. Obviously, some patients have the sphincter inside the prostate. These are the patients that are not going to recover continence long-term, in my opinion. You can do whatever you think in terms of technical modifications, but in some patients, the sphincter is actually inside the apex of the prostate. So when you cut it, you're going to compromise continence. That's why I think we don't have 100% continence rates long-term. Some patients are incontinent after 2RP, right? So it's not a high incidence, but some of them, they get some incontinence after procedures for BPH. But I totally agree with you. Long-term, these patients should do fine. Potency is a totally different history because it's multifactorial. Some patients, they don't have a sexual partner. They get like a lot of anxiety of the cancer diagnosis, and this affects the recovery of sexual function. And again, and then you have the rehab of the penile rehab after surgery that can have some impact in terms of long-term recovery of sexual function. Age, it's one of the most important factors in terms of recovery of sexual function. Also, the basal sexual function prior to surgeries. There are so many key factors that can affect long-term recovery of sexual function that's really hard to predict. And I totally agree with you. I cannot tell my patients, look, long-term you're going to do fine in terms of sexual function. Actually, we don't know. We really don't know, and it's very hard to predict. We did a study with Patel when I was a fellow there with more than 5,000 patients. We look at predictors for recovery of sexual function. And the most important factors were the Sheen score prior to surgery and age. These are really the most important factors predicting 12 months recovery of sexual function. Young guys, sexual function is good prior to surgery. These patients are the ones that are going to do well because, young patients recover fast. Sexual function was perfect prior to surgery. Even if they have a decrease in terms of quality, they still going to do well 12 months later. So that's what I tell patients. I can do the best nerve sparing procedure. I cannot predict your recovery of sexual function, but if you're young, healthy, and you have a very good sexual function prior to surgery, your odds of recovery sexual function are very good 12 months later.
Wholeheartedly. And I think, when anybody starts, it's always the most unknown of how does this go in my own hands? Because there is so much variability, tolerance for possible positive margins, getting a good assessment of their functionality. So I'm fairly similar to you. If it's radiographic T3 disease involving neurovascular bundles, that's going to be a wide excision. That's a kind of, oncologic principle. And similar to you, in the higher risk patients, basically unfavorable intermediate risk on the ipsilateral side of their biopsy, assuming their MRI is clean, it'll be a planned partial nerve sparing or an assessment of the capsule, essentially, as you're doing the nerve sparing. So what I do is once I've completed my bladder neck, so starting out with a posterior dissection, I try to get into a nice intrafascial plane early on, as long as that's sound in my opinion. If they've got a big posterior tumor, then I'll go get onto the perirectal fat. So I try to develop the intrafascial plane. And then when I come to the bladder neck, laterally, I'll grab my SV and, gently kind of rock it. And oftentimes I feel like you can see these shifting planes of where the bundle is and then where the pedicle is. So I'll try to spread in there and then see if I can't pop into my nerve sparing plane, both laterally and now posteriorly. And then, of course, just in between, you have the pedicle, which, in my opinion, the actual prostate pedicle rarely extends beyond the base of the prostate, or perhaps base mid. And then when you've taken it, you're essentially connecting those dots between the posterior and the lateral, and then you take that to the apex. Can you talk a little bit about your nerve sparing technique, Rafael?
Yeah. So, I think essentially we do very similar. What I changed. So I did this when I did finish my fellowship. I was doing exactly like with Patel. I was doing the retrograde release of the neurovascular bundle, which means we're trying to dissect the neurovascular bundle from the prostate prior to ligating the pedicle. And the advantages are because if you're doing an antegrade fashion, sometimes you can get into prostate. You can incise the prostate because you don't really know the limits of the prostate. You have those perforating arteries that if you don't cut it and you try to just push it, then it would disrupt the capsule of the prostate. And by doing retrograde, you define the limits between the prostate and the neurovascular bundle, and you can easily see where exactly the pedicle is and you know where to clip. So I was just doing like in retrograde, but then I realized, look, we have to preserve these anterolateral nerves as well. And that's why when I started doing the retrograde release, like dissecting the neurovascular bundle from the prostate prior to ligating of the pedicle, but without ligating the DVC. So as I said, it's all the same thing, the DVC and the dorsal, the DVC and the neurovascular bundle are the same structure. So you start off your dissection very high, underneath the DVC, and you connect this lateral plane to the posterior plane of the ureter dissection. So we totally free your neurovascular bundle prior to ligating the prostatic pedicle. And this is what I usually do. And I think we are doing, as you described, doing very similarly. And just a little bit like you start, some surgeons like to start the dissection at the base or at the apex. I like to start at mid prostate. I do my lateral dissection. I connect the lateral plane underneath the DVC to the posterior plane, and then I just have to ligate the prostatic pedicle. I even did, in my early experience, some preservation of the tip of the seminal vesicle, like those French surgeons. They're still doing. I was in France last week, and they did a couple of live cases, and they actually preserved the tip of the seminal vesicle still. And my experience is that those patients have a lot of pain at ejaculation after surgery. So I even had to go back and take the seminal vesicle out of 2 or 3 patients because they were potent, but they had so much pain after the intercourse that I had to just reoperate them to take the apex of the seminal vesicle. So I don't do it anymore, and I don't think it makes any difference in terms of sexual function recovery.
And do you use a no cautery technique when you do your nerve sparing?
So I use clips. That's what I like to use. I know there's some controversy if you use bipolar or even other kinds of energy, you could actually spare the nerves like better than using clips. But I think the key points for me are no traction and athermal dissection. I think this is really the key. You cannot compromise. If you do a lot of traction and if you use thermal energy, you're going to have a lot of neuroprax. Those patients are going to take longer to recover. And in my personal experience, this is really key. And that's what I have been doing for the last 10 years. What about you? Use clips, Hemolox? How do you control the pedicle?
Yeah, I use Hemolox. If it's nerve sparing, Hemolox only. If it's non-nerve sparing, and this may be voodoo, I'll use my bipolar to take a nice wide thermal margin, and then I'll clip below, and just for a bit additional hemostasis. So, but if it's nerve sparing, pretty much non-thermal. And even if the neurovascular bundle is a little bit oozy at the end of the case, I'd rather lightly oversew it with a Vicryl than use a lot of cautery. Yeah, I think the traction part is interesting, and it's one of the things that kind of made sense to me about an apical release early, is because so much of that traction when you're trying to define the pedicle is at that fixed point of the apico-urethral junction. So one of the surgeons that I've worked with previously would release the apex before even doing the bladder neck or anything. And it appealed to me. If you didn't get into the nerve sparing plane early, sometimes I felt like it would lead to a bit more bleeding. And, that could obscure the rest of the case, not the end of the world. But ultimately what I ended up doing is just not putting as much traction on the SVs and the VAS when handling my pedicles. Any thoughts on that, on an early apical release?
Well, I think it can be done. I have tried. The problem is sometimes you get it to the bleeding since the beginning of the case, and then if you cut in those veins in the beginning, either you're going to have to suture it or you're going to have some oozing throughout your whole procedure, and then I cannot see the bundles very well. So I try to leave that part of the procedure to the end. So I totally release the prostate. If I get some bleeding from the dorsal venous complex, I'm done with all my dissection. So it's not a real issue. I can just finish the apical dissection. So I try to avoid dissecting the apex early just to avoid bleeding from the dorsal venous complex.
Yeah, that's kind of exactly where I landed. It was mostly just kind of it's nice if they pop right off and you get in the plane and you can work them back. But if you get into a bit of a wrong plane, then, it's inconvenient. So, and then, nerve sparing, it doesn't have to be all or none, right? There's intermediaries. Can you talk a bit about partial nerve sparing?
Yeah, so this is something that we also published a couple of years ago. We look at the radial distance from the prostatic capsule to the widest point of the extraprostatic extension. So how much of the nerves you have to lead into the prostate in order to avoid a positive surgical margin. And you had our pathologist reviewing all these slides, and what we found is 9% of the cases, this distance from the prostatic capsule to the widest point of the extraprostatic extension is just about 3 millimeters. So if you leave just a 3 millimeter margin of neurovascular tissue into the prostate, you can avoid 90% of positive surgical margins in patients with a nerve with an extraprostatic extension. So unless you have a very bulky disease in the MRI, those patients are going to have to do a non-nerve sparing procedure. But if we are talking of microscopic extraprostatic extension, just go a little bit wider, just 3 millimeter margin of neurovascular tissue that has to be left into the prostate in order to avoid a positive surgical margin. That's what we call nerve sparing, and the partial nerve sparing, that's what I like to do. If you look at the guys in Hamburg, they do what they call the NeuroSafe, which is interesting. I like the way they do like a frozen section, real time intraoperatively, and they have a dedicated pathologist to do that. So in 15 minutes, they have the final pathology and they know if they had a positive margin or not. The problem with that, if it was positive, they just go back there and take the whole bundle. So this one I think doesn't make sense. So we have like a 1 millimeter positive margin, we're going to go back there and take the whole neurovascular bundle. I don't think that makes sense. That's why I'd rather do a partial nerve sparing with just a little bit of tissue into the prostate instead of doing a NeuroSafe approach and take the whole bundle because of a small margin that probably will not affect the long-term outcomes of this patient, right?
Totally. And I think that that technically actually a partial nerve sparing is significantly more challenging because you don't have the benefit of being there on the capsule, that kind of shiny egg white. And, if you stay, it's just like if you're digging out the SV or the VAS, right? Like if you're right on it, it's quite easy. But once you're a millimeter or two off, like for an intraductal carcinoma, you're worried about transmural spread into the SV and you're trying to leave some fat and connective tissue on it, that's just a little bit trickier than getting right on it. And same for the partial nerve sparing. In the appropriate cases, either radiographic, micrometastatic, and even those do make me a bit nervous, but to me it would be more of a higher risk patient with, 7, 8, 9, 4 plus equals 7, 7, 8, 9, 10, that I'm a little bit more worried that I would maybe do a partial nerve sparing as you described.
The partial are definitely more challenging because you can either go very close, because when you do a full nerve sparing, it doesn't bleed at all. All the neurovascular bundle is preserved, the arteries are preserved. And when you go very wide, you can also just put clip or use cautery in the whole bundle and then it doesn't bleed. But if you want to do a partial, it's very hard to find the exact, like the plane that we can preserve partially and not getting too close to the capsule. So this is when I think that experience makes the difference when you're doing partial nerve sparing. That's what, it's more the most challenging nerve sparing procedure. And that's why I think you should look for an experienced robotic surgeon. This guy is going to make difference, especially in those partial nerve sparing procedures.
Absolutely. Absolutely. And, we didn't talk much about, actual intra-op or peri-op issues, problems, complications. I mean, I feel like these days, standard surgical technique, drop the pneumoperitoneum, close hemostasis, you really shouldn't have any, significant operative issues or problems. Are there anything that you do to avoid complications, so to speak?
Well, the only thing, I think that, as you said, if you have a meticulous technique, you do a good hemostasis, you shouldn't have bleeding post-op. These are very rare. Then anastomotic disruption, very rare. The way we do the reconstruction, the anastomosis is usually perfect. We can take the catheter out in 5 to 7 days. That's what I usually do in my practice. Something that I'm still not able to avoid are the lymphoceles, because I use a lot of clips and I try to do, I do transperitoneal, I clip everything, and it's still, I'm not able to avoid long-term lymphoceles. Lymphoceles, in my practice, they get infected months after surgery, and that's why I don't know how to avoid it, because you see that patient that had prostatectomy 6 months ago, and they still get an infected lymphocele, and I actually don't know how to avoid it. If you have any tip or trick that you could give me to avoid long-term lymphoceles, that would be great.
Have you tried this peritoneal flap interposition at all? Are you familiar with that?
I haven't seen it. I have seen the description. I tried. I was, it's hard without a study. It's hard to say if it works, and if not, it doesn't work, because, as I said, most of my cases are months later, months after surgery. So you actually don't know if it works or not. But I would give it a try. You're doing that in your clinical practice?
I don't, to be perfectly honest, but I totally hear you. Every year there's some guy that had a prostatectomy 3 months ago, comes in with some leg swelling pain, and like out of the blue, they've got an infected lymphocele. And as you know, it's a bit of a, drains and antibiotics and pull drains and blah, blah, blah. Like it can be a bit of a to-do. So I don't do them. I use clips of bipolar fairly extensively for my lymphadenectomy, and I think there's actually a randomized study that shows that clips and bipolar are fairly equivalent. I haven't done the peritoneal flap. I understand it takes like 2 minutes, and I don't think there's going to be a randomized trial. There probably shouldn't be a randomized trial because it's such a small point, but something to consider trying for myself and other people. I have talked to some fairly high volume surgeons that kind of swear by the effectiveness of it, but I haven't done it myself yet. Yeah. And then, if it's not necessarily for prostatectomy lymph node dissection, but if I do robotic RPLND, I do use tissue sealants, VistaSeal, TisSeal fairly extensively. And it's kind of anecdote, but I will, if it's a bit oozier than I like, I'll either put some Flow Seal or Surgiseal or something in at the end of the case, but that's kind of case by case. Excellent. So, I think we've talked about at least there's pentafectas and quadrifectas and sextafectas, and it goes on, but I think it's safe to say that at a high volume center, perioperative complications should be uncommon. We've talked quite a bit about, the oncological things we can do to maximize the likelihood of surgery alone being curative, and making a good assessment of, what's going on in terms of lymph node metastases. We've talked about, a fair number of tips and tricks to help preserve continence, and then, of course, erectile function. So maybe at this point, Rafael, I would just ask you, are there any kind of parting thoughts for the listenership as they're considering either doing a prostatectomy or counseling their patients?
Well, I think you pretty much covered the most important tips and tricks for radical prostatectomy. And I think you have to choose one technique, because, I have seen surgeons, they try to change all the time, and they start with one kind of surgical technique, and then 2 months later, they try to do something different. And then if you do that, you never get very experienced in one single, way to do a radical prostatectomy. So what I would recommend, like, choose your technique. There are many ways to do it. And once you choose it, you should get very experienced and optimize your outcomes by surpassing the learning curve. You have to do a lot of things, the same thing, and then you're going to optimize the way you do a radical prostatectomy. Don't keep changing, don't keep moving to rectus sparing, then going back to an anterior approach, or doing an antegrade sparing, then you move to a retrograde sparing. Just choose the way you do, the best way that you can, and keep doing it so you get experience on the best way to do the radical prostatectomy. So this, I think, is a key point for having good outcomes long term.
Well, Rafael, it's certainly nice to connect with you. You were an amazing host when I came down for the AUA SBU exchange program. And, watching you operate was absolutely a treat. If anybody can track down a video or spend some time down at ESESP, it's something else. So look forward to seeing you in New Orleans. And thanks again for all of your excellent tips and tricks. Really appreciate it.
Well, thank you for having me here. It's going to be great to see you after the pandemic, after so many years without having a beer together. So I'm looking forward to see you at AUA this year.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team lead is Kieran Gannon, with support from
Caleb Hodson
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz, with support from
Ishad Sangwan
and Vedavi Patwardhan.
Social media and PR by Chi Ding.
Thanks again for listening, and see you next week.